So this patient is presenting with hip pain.
So this is a pelvic reading of a skate speed patient. I can see there are bilateral total hip replacements. I can't see the distal aspect of the right THR stem. I would want to see if there's any other images available. I note that in the right hemipelvis, there is cortical thickening involving the right superior and inferior pubic rami, and also the right iliac bone. When I compare it to the left hemipelvis, there's expansion of these bones. There's also some increased trabeculation involving these in these bones. My primary differential here would be Paget's disease. I would want to see if there's any previous imaging available. Possibly there is because of the surgical history. I would want to see if these changes are new. Just looking at the rest of the bones to see if there's any other abnormal appearing bone. I think the main findings are in the right hemipelvis. And if this is new, I think my differential hasn't changed. I would have had disease as my main differential, and I would suggest further imaging with nuclear medicine studies to see if there's any other bones that are affected. And
so the previous radiograph showed the Paget's disease, so that is unchanged.
Okay. The right, the lesser trochanter of the right femur appears to have a loosening lifting lesion, especially when I compare it to the left side. There's also cortical thinning. There's no periosteal erection at this site.
I think that's fine because you can see the lesser trochanter is slightly loosened and it appears like that, when due to the depending on the rotation.
Okay.
So, if is there anything else that you would be worried about?
Yes, I mean, if this patient had known Paget's disease, I would still compare with the previous radiograph to see whether there's any changes. There is osteosarcoma formation in Paget's disease. So if the patient is having new pain or worsening features, then I would recommend further imaging.
What further imaging?
I think an MRI would be suitable.
Okay, fine. So I can show an MRI for you.
So the fluid sensitive sequences presented in the coronal plane. Can I scroll through these images?
Yes.
Oh, okay. So it's really the right hemipelvis which I was going to focus on here.
So that's the stir image, and I can also show you the T1 weighted image. And I'm not sure whether you heard it's right-sided pain. Yeah.
Yes, right side.
Yeah. So right-sided pain. So I'll go back to the stir coronal again. please feel free to stop me at any image if you want me to just go through it very slowly.
I guess I didn't clarify whether this pain has an acute onset with a background of bilateral hip prosthesis. I would want to ensure there's no periprosthetic fracture or loosening.
No acute injury.
No acute injury.
Okay, fine. So we'll go to the next case. So this is a young patient presenting with knee pain, and I can put both the radiographs together for you if that's better.
Thank you. The radiograph leads the image. On the AP view, that there is aggressive appearing periosteal reaction involving the lateral cortex of the distal femur, giving a Codman triangle appearance. Within that region, there's also some appearance of a soft tissue component here. Looking at the adjacent bone, there's some kind of irregularity of the cortex, but I can't appreciate any lesion within the bone itself on this view. At the lateral, if you could kindly zoom in on that for me, please.
Yes.
So again, on the lateral view, I can appreciate this periosteal reaction posteriorly. It's giving the appearance of a Codman's triangle. There's also abnormal soft tissue posterior to the femur. So I'm concerned here about an aggressive pathology. I can't keep the lateral. I can't see an intraosseous lesion. But I would be concerned about soft tissue osteosarcoma at this point. And I would keep that as my first differential and would want further imaging with MRI to assess this region better. Also, urgent orthopedic review.
Okay. So MRI of this patient.
So this is the coronal fluid sensitive. Can be see an abnormality, bony lesion now in the distal femur metastasis. It's this heterogeneous high signal. It's lobulated. This thinning of the cortex. I would scroll through the rest of the images to see if there's any cortical breach or any fracture through this. There is a surrounding large joint effusion. There is cortical breach, yes. So there is cortical breach on the lateral side.
I'll get the axial for you. I mean, your time is up, but we will look at this case. Yeah. So you can continue describing. So if I zoom this in, and these are the axial images.
Yes. So there's significant kind of surrounding bony edema. and is it well encapsulated soft component to it. It's high signal on fluid sensitive images. This could represent a chondroid lesion.
Okay, fine. So what we'll do is I'll just describe this lesion. So you pointed exactly correctly on this Codman's triangle, aggressive periosteal reaction. There's sclerosis, increased sclerosis in the bone. Okay, and then if you look at this, there's a big soft tissue component to it. Again, you can see the aggressive periosteal reaction, and you can see the periosteal reaction here, which is very immature. Whenever you have periosteal reaction that is very immature, and you have it raised, that is because the bone is not able to cope with the aggressiveness of the lesion, and therefore the periosteum doesn't have time to get laid down. Yeah?
Yes.
And when you are looking at this here, this is not effusion, okay? Because that's why I was trying to show you this image here, because that's a little bit of fluid in the joint. Yeah, there's not much effusion here. What you're looking at is this is the periosteum, okay? And this is that's why the soft tissue component is so much that the periosteum is. Can you see this is like the cortex here?
Yes.
So it has been raised, and we have what we call sharp-based fibers. So can you see this striation within the
Yes.
periosteum and the cortex there? So that is the striations. That's the sharp-based fibers. And what happens is the process is so aggressive that it cannot then lay ossified bone here, and that's why you're seeing it the way you're seeing it on the plain radiograph. And this whole thing is then infiltrated by the tumor. So in a young patient, and if it is metaphyseal based, then osteosarcoma will be the first one. If something is diaphyseal based, then Ewing's will be the first differential that you will be giving. But main message is that this is an aggressive primary bone tumor in a young patient, and in this case, it has crossed the physeal plate and has gone into the epiphysis as well. It is really aggressive, with periosteal reaction as seen, and also a soft tissue component to it. What you're looking for is local staging. So you will complete the explanation saying that because this is a primary bone tumor, this has to be sent urgently to the tertiary bone center. And when you are actually doing the local staging, you need to make sure that the proximal joint is also included in the local staging, because you want to make sure there are no mets, skipped metastasis that are there in the bone. Yeah, so that
Yes.
will be part of the MR that you will do, and you may need to. I mean, you will need to do CT of the chest to look for metastatic disease there. But first thing is, refer it to the bone tumor, because some of the tertiary bone centers have their own protocol that they need, because that will be the site where they will decide what kind of surgical intervention is required. Yeah.
Okay. Yes. Yes.
Okay, so that is a osteosarcoma. So the plain film interpretation, very good, because you got all the points. MR, I think you can look at a little bit more cases. Just don't be, um, you know, um, thinking that something that is fluid density is fluid. It can be like solid lesion as well. Yeah.
Yes.
Okay, fine. So that is that case. Then we had the one. So this one here, load. So young patient again, and we're having the lesions. So you picked up that there were two lesions here, one and two. I think it is difficult, but that's why I was trying to zoom it in to show you, that lesion. And in the exam, you will have a little bit more control as well. But you can, then make sure that you are seeing whether there's another lesion. So you can see that here and see that here. Now, the main thing is this medullary based or cortical based? Because your differential will change if it's cortically based lesion.
Yes, they are both cortically based.
Yeah, they're both cortically based. That's very good. So cortically based lesions in a young patient. What will be the first thing that you think of?
Uh, Osteosteoma, osteoblastoma. Uh,
But there's no
fi-
sclerosis.
so
Because
fibrous.
osteoma will have a lot of sclerosis around it, isn't it? And the
Yeah,
nidus will be very small. And remember, we are also looking at something that can be multiple. So what else will you think about?
fibrous cortical defect.
Yes, fibrocortical defect. Yeah. So this was non-ossifying fibroma or fibrocortical defect, and if you saw only one, I think you'll be happy. But because there are two, you were a little bit hesitant about making that diagnosis. But remember, if it's a fibrocortical defect, how many ever I show, it's still fibrocortical defect. Yeah. So I will
Yes,
show you the MR for that because you can do MR. In this case, they wanted to know how many more are there. That's why we did the MR. So there's one here, there's one here, and there's one there. Can you see?
yes, yes. Okay.
Okay. And they're all cortical based, like you said. Okay. And they all are well defined, and there's no aggressive bone marrow edema or anything associated with it. So I will load the axial as well, and you can see it's cortically based lesions
Yes, yes,
there, there. Okay, so they're all cortically based and they are well defined, and they are when you look at the plain film again, if I load the plain film again, they have the typical um, they look multiloculated. Can you if I zoom that again, see, they look multiloculated, they have that soap bubble appearance, and they are cortically based
yes,
and lucent. You said eccentrically placed. That's the first thing that you used, isn't it?
yes,
Eccentric place.
yes,
So those are all very good descriptions, and I think your hesitation was because they are multiple. You wanted to give some other differential. So I think you did give acute leukemia as one of the differentials. Yes, it could be, but it doesn't. If you look at it, this is more like soap bubble appearance rather than that aggressive periosteal reaction.
yes,
Yeah. Okay. So that's the thing. And if they give you MR, don't be like put off. Oh my God, I've seen one more lesion that I didn't see because that lesion was not included in this, so that's why you couldn't see it. And MR, the main principle is that they all are well defined. They're all cortically based. And
yes,
I think some of the candidates, sometimes what happens is when the MR is given, they think, oh, I must be wrong. That's why they're giving MR. No, we are showing the MR just to confirm what you thought on the plain film. If you thought it is non-ossifying fibroma on the plain film, we're just giving you the MR to confirm that. Yeah. So this is MR appearance of non-ossifying fibroma. I don't think they usually anybody will do MR for non-ossifying fibroma, and I don't think they will expect you to know this. But when you have multiple non-ossifying fibromas, they can be associated with a syndrome called Jaffe-Campanici syndrome. That is because they can have neurofibromatosis, like capillate spots and type 1 neurofibromatosis features. Yeah,
okay,
but I don't think they will expect. They just want you to identify that it is non-ossifying fibroma. That's all. Okay,
yes, okay. Thank
fine. And then going on to the other case with the Paget's disease. So I'll put this up. Uh, so fine. So one of the main things is the fact that that's Paget's, and you were very confident, very good. So gave a good description of Paget's hemipelvis and coarse trabecular pattern, and the fact that it also has cortical thickening and increased sclerosis. So all very well described. But you were, I think, sort of coming to periprosthetic complications, because I think last session also I said, because we have aging population and we have the processes staying for longer, we need to know the periprosthetic complications, and that's one of the things that they can present with. And you can see that there's increased lucency here, around the acetabulum. So I was waiting for you to say something more about that, and then I was trying to give hint that it is right-sided. But you're right, you have to think about osteosarcoma transformation of the Paget's, which can present with pain. But you also need to remember that, oh, the patient has prosthesis. Could it be prosthetic related? I think you came back to that when we looked at the MR and you asked whether there was history of any trauma, because periprosthetic fracture can give you that pain. So that was good. But if you look at the MR itself, you can see that there's this pocket of fluid that you can see. Can you see this?
Yes.
Yeah,
Yes.
and
Yes.
it has a black rim around it.
Yes.
You can see that as well. And if you see, it then continues, with some inflammatory changes in the iliopsoas region. Okay, so one of the things that you get, as you know, with periprosthetic loosening is pseudotumors, yeah, or you can get like bursitis and other changes. And the if I go to the T1 here, so you start getting changes in the marrow as well, yeah. So you can see the marrow here; it's nice and clear. Then you start getting lucency. That's the lucency that you're seeing on the plain radiograph around
Yes.
this.
Okay.
Okay, so those are the things that you are looking for, and they will give you even bigger example of a big pseudotumor. But it is something that you need to recognize, that you are looking for on the MR any fluid collection, any tumor like mass, any changes in the marrow with loss of the normal fat, and it is replaced by this granulation tissue, because basically it's an adverse reaction to the metalwork, isn't it? That's what is happening.
Yeah. Okay.
Okay, fine. So yeah, so I think we did those three cases. Any questions on those three?
Uh, my question was, sorry, going back to fibrous cortical defect case. Uh,
Yes.
what threw me off there was that the lesion affecting the medial metaphysis. I thought it had aggressive looking features. That, I think, threw me off. On the radiograph, is that possible for it to have cortical breach and
So you're saying this?
yeah, yes, yes,
That's what I was trying to tell you, that it's like that soap bubble appearance that you get. There's
yes,
no
okay,
breach at all, because on the MR I showed you
yeah.
there's no
On the
breach.
MRI, it looks, yeah,
Yeah, it's just that typical soap bubble appearance, but you're looking at it as a tangent.
yeah, okay,
Yeah. So when you're looking at it as tangent, it looks as if it's this is raised, but it's just the lesion itself.
I see.
Yeah.
Okay,
So if I go back to the MR, then can you see that?
yeah, yeah.
Yeah. There's no breach of the cortex
There's
or
no
anything.
breach. Yeah.
Yeah. Okay.
Okay,
Fine.
thank you. Thank you very much.
Thanks. Fine. So candidate number two.
Yes, I'm here. Can you hear me?
Yes. Yes. Thank you. So fine. So let's go for. Uh, okay. So this is a young patient who is presenting with bone pain.
Okay. So these are the T1 weighted images, T1 weighted MRI images in coronal plane of both bilateral tibia, showing multiple uh, multiple areas of serpiginous lesions involving the metaphyseal region, proximal and distal, as well as proximal tibial epiphysis. It has on T1 weighted images, it has hyperintensity within the center surrounded by a hypointense rim in keeping with sclerosis. Uh, so this is giving a double rim appearance. I would like to see the lesion on T2 weighted images if available. Okay, so the T2 weighted fat suppressed images show that there is suppression within the center of the lesion with surrounding hyperintensity. These findings are in keeping with bone infarct, and given that they are bilaterally, I would be worried about some systemic condition like sickle cell anemia, or if the patient is on long-term steroids. So I would like to look at the other uh, body parts or other radiographs of other joints if available, and refer this patient to. Okay, so similar findings are seen in bilateral femori, confirming that uh, these are bone infarcts uh, involving multiple bones. Uh, so I would
So the causes you could you give the causes of bone infarct in young patients? So sickle cell anemia.
sickle cell anemia, Gaucher's disease, uh, or uh, if the patients are on long-term steroids. Mm,
Yeah. Okay. Fine. So good. So we'll move to the next case. Okay, so this patient is presenting with increasing pain around the knee, and I have, few. Let me put these two together for you. So please let me know how you want the images. Do you want them side by side, or do you want one by one? I can do whichever you want.
I think I would prefer side by side. This is good.
Mhm.
Uh, so these are the T1 weighted images and T2 weighted fat suppressed images in sagittal plane uh, through the femur side not labeled. So I can see that there are multiple lobulated lesions in arranged in a linear fashion with intervening cord-like structure. Um, the west popliteal artery is anterior to the lesion, separate from it. Uh, so these lesions are iso-intense to muscle on T1 and hyperintense on T2 fat suppressed images. There are there any post-contrast images available?
Suppose contrast.
Okay, so post-contrast images show heterogeneous enhancement of the lesion. Uh, I think these could represent multiple neurogenic tumors uh, along the nerve. They are or Other differential could be venolymphatic malformation, venolymphatic slow flow malformation. Uh, but there are no fluid levels within. I would like to check the radiograph if there are phleboliths in this region. However, my primary differential would be multiple neurogenic tumors. Uh, so I would be worried about a neurofibroma, a neurofibromatosis. So I would like to review the patient's history and images or previous if there are any similar lesions in other parts of the body. I cannot see any cutaneous lesions in the provided image. Um, so I
And
would
what are the features of neurofibromatosis?
so there
The
are multiple.
features for
Sorry,
NF1, would you know?
sorry. Could you repeat that? I missed it.
Uh, for NF1,
Hmm.
any other features for neurofibromatosis type 1? Are there any other features that you would know? What are the
So there
manifestations?
are multiple neurofibromas. There is plexiform neurofibroma, um, and there are like tibia pseudoarthrosis, scoliosis, kyphoscoliosis of the dorsal spine. There could be multiple spinal nerve neurofibromas or meningocele associated.
Yeah. Okay. So this patient is complaining of pain in the left hip.
Okay, so this is a AP radiograph of pelvis in a skeletally mature patient showing left-sided hip orthoplasty with prosthesis, and I can see that there are multiple uh, fragmented fragmentation around uh, the around the head, around the prosthetic head. Um, I would like to know if the patient has any history of trauma.
The only history is bent down and extensive pain.
Okay. Um, so there are multiple fragmented high density fragments around the head of the left femur prosthesis. Um,
You have a
uh,
lateral if you want.
yeah,
Please ask for lateral usually. Yeah?
yeah. Okay. So the lateral radiograph of the left hip joint shows confirms that the head is deformed and there are multiple fragments. Uh, there is no lucency around the stem of the prosthesis. However, I would like to compare with previous radiographs, if available.
So previous radiograph doesn't show any lucency around the process or around the stem.
Okay, so given the clinical history and the findings in this radiograph, I would be highly concerned about uh, fracture or injury to the prosthetic head. Ceramic, it looks like a ceramic head. So, and I would refer this patient urgently to the orthopedic team as this requires urgent management.
And so you think it's a ceramic head fracture, yeah?
Yes.
So we'll go to the next case. So this is again a young patient who's presenting with swelling and pain in the left knee.
Okay. So this is a frontal radiograph of left knee joint in a skeletally mature patient. There is a lucent lesion involving the medial femoral condyle. in the epiphyseal region. It is well defined with sclerotic margins. There is narrow zone of transition. There is uh, there is thinning of the overlying cortex. However, I cannot see any obvious cortical erosion. There is no periosteal reaction or extraosseous soft tissue component. The matrix of the lesion shows uh, calcifications within, uh, most likely in keeping with um, chondroid matrix. Um, so my differential for this would be a, a, con, a low a chondroid lesion, a well-defined chondroid lesion like in chondroma or other differential. However, the site is metaphyseal. So other differential would be giant cell tumor um, in this patient. So I would like to look at the lateral radiographs if available to see if there are any additional findings.
That's the lateral radiograph.
Okay, so the lateral radiograph confirms the presence of a well-defined lucent lesion with calcifications within. Um, so my differential for this would be um, a low-grade chondroid lesion. Um, I would like to know if the patient has any known primary, in which case it could represent metastasis, however unlikely.
So why do you say it's a metastatic lesion?
It shows benign features. However, in a skeletally mature patient, I would still want to rule out if there are any known primary. If the patient has any known primary, it could represent sclerotic mixed lytic sclerotic metastasis.
Okay, and where is the lesion in relation to the bone?
Okay, it is eccentric. Yeah.
Okay.
So okay, I think I will put a giant cell tumor uh, as a main differential.
Okay. So PCT was your main differential. So let's go to the next case. Uh, so this patient is unwell and has been on you know follow up on treatment, and this is the CT scan of the chest.
Mhm. Okay. So these are the CT scan images in lung window of an unwell patient showing multiple lesions in bilateral in both the lungs. There are bilateral pleural effusions more on the right side. Um, I would check for the mediastinal and bone window in the patient to see if there are any other findings. To the left.
So that's your time, but we'll finish the case. Yeah, so you can relax now.
So there is right hilar lymphadenopathy. Um, Okay, so there is mediastinal lymphadenopathy as well. Uh, so so there
Okay,
are
so this mediastinal lymphadenopathy, there are multiple focal lesions, there are
lesions.
bilateral effusions, yeah,
Yes. Yes. So
and patient is unwell.
patient is unwell. So
Right?
I think this could. So if the patient is unwell, I would be concerned about septic emboli with uh, lymph with infective lymphadenopathy. However, there were no cavitations within the pulmonary nodules.
Mhm.
Just okay, the abdominal CT scan. Um, mm,
So I put it in bone window because the bone is,
okay.
what are you seeing here?
Um, there is uh, uh, the iliac side is quite dense uh, in bilateral I along the SI joints. The okay, it
Where
is
are the SI
present.
joints?
There are few. Okay,
Yeah,
yes. So there is erosion. They're
yeah,
fused. Yeah.
they are fused, completely they're fused, yeah?
Yes,
So
yes,
because
they're
it's a
fused.
continuous line, look at that, it's a continuous
Yes,
line, see?
yes, yes.
Completely fused. It's not like sometimes you can get what we call flowing osteophyte or bridging osteophyte across. Yeah, but this is
Mhm.
completely fused.
Yes,
Okay, and you can see that there must have been some erosion or some changes there because it's all loosened here, but it's now
mhm.
fused. Okay,
Yes,
so
yes.
this was a very interesting case from the point of view, and you can see these joints also. There are many
Mhm.
joints that appear fused.
Yes, yes.
And if I go, to the chest also, if I go on the bone windows there, you can see some of the costovertebral joints also. They look,
Mhm.
fused.
Yes, yes.
So fused SI joint, fused, posterior elements. What are you thinking about?
Um, ankylosing spondylitis. Uh,
Yeah, using spondylitis. Yeah. So and this patient is on ANF. Uh, you know, um, I mean TNF, tumor necrotic factor, yeah, and
okay.
because of
Mhm.
that, immunocompromised and developed miliary tuberculosis.
Okay.
That's why he's unwell. That's why you have
Mhm.
bilateral, effusions, and you have
Mhm.
multiple, lung pathologies, and you have lymphadenopathy as well.
Yes.
That's acute TB. And one of the features I mean, the rheumatologists usually do X-ray now for all the patients before they start the anti-TNF treatment, because if there is, primary Ghon's focus or something, it will get reactivated because of
Mhm.
that. So routinely they do this, and this patient, he was just immunocompromised, and that's why he had focal lesions and the tuberculosis. Yeah. So again, you have to think about tuberculosis. Otherwise, if you even send the pleural fluid for normal culture, it will come back negative, and you have
Mhm.
to specifically ask for AFP.
Okay.
Otherwise, they will not test for tuberculosis. When the
Mhm.
normal microbiology form doesn't have tuberculosis is an automatic thing that you test for.
Okay.
So think about if the patient is immunocompromised, could it be,
Mhm.
a different manifestation? Could it be tuberculosis? Okay.
Okay.
So yeah.
Yes.
So this is the last case. So I'll go back to the first case. So it was multiple infarcts. That was very good. So that patient, I will go back to this, and very well described. I like the description. serpiginous lesions. Usually, it's metaphyseal, and it also has changes on the uh, T2 weighted images or the stir images, because it can be acute on chronic. It's sort of ischemic and then dying, and then it goes through the process of fatty replacement after it's done, and then it becomes sclerotic, which is what you see on the plain radiograph. These areas as sclerotic. It will be low signal intensity on both T1 and on stir images. So very well, described, and also in the distal femur. Okay, so but one observation for you would be, please ask for the other view. Please ask for
Mhm.
to scroll through the full set of images, because you may otherwise miss something. Yeah, so
Yes.
that will be
Yes.
one of the take home for you. Don't hesitate, ask, because that's what you will do in normal practice, isn't it? You will
Mhm.
go through all the
Yeah.
images and you'll ask for other further views. So this patient actually had acute leukemia, and you're right. So then had the bone marrow transplant, and therefore was on high dose steroid, and
Mhm.
that's why it developed all these changes. But you're right. You gave sickle cell anemia, and high dose steroids as the main differential for these changes. Okay, so this is case number 25, so I'll cross that off. And case 5 was schwannomatosis, but it can be, I think it's difficult on that case to say exactly whether it's neurofibromatosis or schwannomatosis, because they are both neural based lesions. And then you ask for the post contrast. Yes, they will have heterogeneous enhancement, but they can be avidly enhancing lesions, which is what we showed here. Because look at the T1 here, yeah, and then look at the T1 post contrast here. So avid enhancement. So good. And I think even last time, when we were talking about discitis and other things, they will ask you a little bit more probing questions to just know, do you know a little bit more about neurofibromatosis? So you answered very well. So don't hesitate to, then show off your knowledge about neurofibromatosis. It all came together. What are the other manifestations? You can go like it is multi-systemic, so skin, and then in the muscles what happens, and in the bones also. Like we said, the non-ossifying fibroma are related and seen in neurofibromatosis. So it is like, because it can affect many systems, you can have that kind of an approach and say, skin manifestation, this manifestation, lungs it does this, in brain it does this, in spinal cord it does this, and optic neuritis, it's one of the features. So just know, the other features, so that when they do give you the, it's quite obvious, but there are big lumps there, and when you get to the diagnosis, you just want to know a little bit more about these
Mhm.
conditions. NF is quite a for exam, for 2A, for 2B, they can ask you a lot of questions. Okay, so well done
Yeah.
on that. And the last one that you did was 22. So coming to that one, so load. So this one was, like I said last time, I will show you cases with periprosthetic complications, and this is one of the cases where so that's the ceramic head that is there. So if I go back and share the cases, so that I can get out of here, then I'll zoom it for you, and move it so that we have it centered so that you can see it. Okay, so you can see the head here, yeah. So we talked about the liner as well. So if you see, this whole thing seems to have moved because the liner inside the head has broken, and that's what is in pieces. But I think as long as you identify that there is compromise of the processes, and it is likely to be, ceramic because of the density, and therefore it needs urgent referral to the orthopedic surgeons, which is, all the things that you said. uh, my only thing would be like, you didn't ask for the lateral for a long time. So
Yeah.
and I had to say, do you want to look at the lateral? Because I
Yeah.
was trying to show you this. Because if it's the head, then you
Mhm.
shouldn't see this at all.
Yes.
Yeah. So
Okay. Yes.
because it's the liner, you can see it's the shape of the thing, but that's,
Mhm.
and you can see that it's more linear than, like, circular, like for the head. Yeah. So that's what I was trying to
Okay.
show you on the lateral. So,
Yes.
but please ask for the lateral. Don't
Yes.
say
Yes.
that, because I want to know whether in your normal practice you look for the lateral.
Mhm.
Yeah.
Yes. Yes.
So
Yes.
please do that. And otherwise, yes, you said all the right things. And prosthetic, periprosthetic complications. It's one of those examinations that can be asked even in 2B, and also for your day-to-day
Yes.
reporting. It's very
Yeah.
important. So that's very good. So I think those were all your cases. I haven't missed any. No, no, no.
Yeah.
26.
There one. Yeah. There is I think one more.
Fantastic.
Yeah.
Okay, fine. So what happened here? Like, you went
Yeah.
very nice. So I thought you were going to smash it, and
Yeah.
you're going to say, okay, this is
Just
uh,
done.
chondroid
I think it.
has.
I got confused between giant cell and then chondroid, and then I thought, okay, like chondroblastoma is epiphyseal, but it is a mature skeleton, and then I got all
Yeah,
confused.
yeah, but I did say it's young patients still. I
Yes.
gave you
Yeah.
young patient presenting. So young patient, chondroid lesion in the epiphysis equals chondroblastoma.
Chondroblastoma. Yes.
Yeah, okay.
Yes.
So because you
Okay.
described everything, and I thought, she's going to just say it's chondroblastoma. Then I thought,
Yeah.
oh, what happened here? Like, so, okay. So, and the other thing is GCT in more than less than 30 is very, very unusual. Yeah.
Okay.
There are case reports. I'm not saying it will never happen, because you do get, 0.001%, or, one case report here, one there. You can get them. But as a
Yeah.
rule, if you are going to describe lesions to me and say in 20-year-old, GCT will not be in the top differential, I'll completely agree with you. Okay.
Mm-hmm. Okay.
So,
Yeah.
especially given that this is all the chondroid, I mean, you
Mm-hmm.
described it very nicely. So, I think stick to your guns and say
Okay. Yeah.
chondroid lesion, and it is in the epiphysis, and only
Mm-hmm.
chondroid lesion I know in the epiphysis is chondroblastoma. That's it.
Yes, yes. I was about to say chondroblastoma, and then I realized, okay, it is not a immature skeleton, and then I shifted completely.
Yeah. And so I was going to show you the CT just to confirm, the
Yeah.
ring-like, the arc-like, calcification.
Mm-hmm.
That is very nice example. See?
Yes,
Yeah.
yes,
So
yes.
it's a nice example. But remember, chondroblastoma, there can be breach and all that. Then I thought it's going to confuse you even more, because you'll think, oh, it's aggressive. So that's why I didn't show
Mm-hmm.
you that. And I thought, okay, I'll leave it at that. But this is a chondroblastoma, that's all.
Okay. Yes,
Okay.
yes.
So there's MR and thing. And the other thing, the other message I want to give all the radiologists who are attending today is, please do not try and interpret an MR without a plain radiograph, because on the MR this looks very aggressive, right?
Mm-hmm.
It
Yes.
looks like, oh, something is, there's a big soft tissue couple, something is very, very horrible is happening here. Look, yeah.
Mm-hmm.
So, but please do not interpret that without the plain radiograph. Always have the plain radiograph when you're interpreting the MR.
Yes.
So, if somebody has done only MR, please ask for the plain radiograph. Okay, because something that
Yes.
looks very aggressive on the MR is actually a benign lesion, but because it has very good contrast resolution, it will show it, on the especially on the stir images, it will show as if it's very aggressive. It's just chondroid tissue there, that's all. It's just chondroid tissue. And chondroid tissue, like, any cartilage, will be high, isn't it?
Yeah.
So this is a chondroblastoma. Yeah.
Yes.
Any questions on those lesions
No.
or on those cases?
So sorry. In this particular image, like if I say only chondroblastoma, do I have to give differentials or just one? Like just say it is a chondroblastoma.
Yeah, I think it's very difficult just because the chondroid calcification is there.
Mm-hmm.
Yeah, and it's epiphyseal. It's a young patient.
Yes.
Yeah,
Okay.
so then you narrowed it down a lot, like
Yes.
So I gave you a young patient,
Yeah.
gave you the thing. So I think there's not much differential that you can give here because GCT will not have this kind of chondral calcification within it.
Mm-hmm.
And
Yes.
like I said, it's less than 30. It's very unusual.
Okay.
Yeah.
Okay.
So
Yes.
there
Yes.
are not many epiphyseal lesions that you get actually.
Mm.
Yeah.
Yeah.
Okay,
Yeah.
fine. So
Yeah. Thank
thank you for
you.
that. So next candidate number 3.
Hello there, Dr. Josh.
Yes. Okay. So shall we go? So this patient is again presenting with knee pain. It's lateral.
Yeah.
First, let me show you an AP radiograph. And they're about 40-year-old.
Okay. So I'm presented with the anterior posterior view of the knee. I'm just having a look to see if there's any fractures or lesions. I think I could see a slight lucidity at the medial aspect of the femoral condyle. I'm not sure if that's projectional. Just having a look at the fibula, the mid-fibula, there appears to be irregular appearances of the cortex, which is, so do you mind zooming in a little bit? Sorry.
Yeah, I can zoom in. So you want me to zoom into the fibula?
Yes, please.
Okay.
Yep. So I can see that there are regions of periosteal reaction extending from the proximal aspect of the fibula, extending to the mid and possibly distal fibula. This is rather irregular, and again, the micro scalloping of the cortex, but I cannot really see any sort of lucency or expansile lesions within. The tibia appears unremarkable, and the surrounding soft tissue does not appear to be grossly swollen. So given this appearance, and this wide zone of transition, I suspect that this is an aggressive lesion. I would also like to, in my normal practice, I would compare this with previous radiograph to see if this is present then as well. However, if this is a new lesion, I suspect this may be an aggressive lesion, such as Ewing sarcoma, or given that is in the correct location, the diaphysis, or less likely osteosarcoma. So I would like to perform a MRI to further evaluate this. I may also look at the lateral as well.
Yeah.
Thank you. Okay, so looking at the lateral radiograph, yeah, same findings are noted that there are irregularity across the cortex, the anterior posterior portion. Again, this only seems to cover from the proximal to medial diaphysis of the fibula. In my usual practice, I also interrogate the knee and the patella and knee joints to see if there's any fractures or involvement there as well. So as
No history of trauma.
no history of trauma. Okay.
Okay, so you wanted an MR scan?
Please. Okay. Okay, so I'm presented with a fluid-sensitive, fat-saturated image with, I believe, contrast, and there is significant edema and high signal surrounding the fibula, involving the soft tissue and likely the entire fibula from in this image. There's expansile appearance, and yeah, gross enhancement. This confirms that this is more of an aggressive lesion, and Ewing sarcoma is suspected. To further the management, I would like to refer this patient to a tertiary center for further evaluation and MDT discussion in view of biopsies for confirmation. I will also perform a staging study to see whether there's any further lesions identified across the body.
Okay, I mean,
Also look at the
the age of the patient is 45 years.
Oh, okay. Okay, that would change my diagnosis. So look at the marrow. It does seem reduced in intensity. So there's loss of fatty marrow. Given that is on one part of the fibula only, lymphoma may also be on the differential, but again, 45. I'm also thinking of any other. Again, osteosarcoma may be also on the differential.
Okay, so aggressive bony lesion, lymphoma, osteosarcoma. Yeah.
Please, thank you.
It's very slow.
Thank you. Okay, so I'm presented with a chest radiograph. Super, I can see that there are multiple leads. I believe there's an ECG leads. There's no other lines that I can appreciate. Just having a look at the radiograph. Okay, so I can see that there are some bulky increase of fluffy appearance of the hilum, more so on the right mid to lower zone, the pericardial region. I'm just having a look at the lungs on the other side. I cannot appreciate any collapse or consolidation. Looking at the bones, the scapular and humerus are remarkable, no signs of dislocation or fractures. Looking at the ribs, I cannot see any bony outgrowth or bony destructive lesions. The cardiac contours are well delineated, and the heavy diaphragms are also well are clear. In my usual practice, I would look at the APCs to see if there's any or the transparent angles to see if there's any signs of pneumothorax, which I cannot appreciate here. So in this chest radiograph, I can see that there are densities across the the right cardiac region in the lungs, which may indicate consolidation or may indicate pulmonary lesions. What it would be helpful to know if there's any whether the patient is or what symptoms the patient came in for.
So they're complaining of pain in both shoulders.
Shoulders, okay. So I'm looking at the shoulders, looking at the clavicles. I can see that on the left, there's a slight resorption of the distal clavicle. Likewise on the right. Would it be possible to zoom in closer onto the left clavicle? So I can see that there are slight resorption of the distal clavicle on the left, with widening of the clavicular joint. I would like to perform a shoulder X-ray radiograph to compare, and also like to look at previous imaging to see if there's any, if this was a new finding or is this a ongoing kind of issue.
This is the first radiograph, presenting radiograph.
Okay, so there's slight osteolysis, sort of demonstrated at the distal clavicle as well. Can I also see on the, you can zoom in on the right side if that's okay. If there's any, that was the same. Okay. There is also osteolysis seen on both sides. I'm trying to think. It's I would okay. I think what I'm suspecting this may be related to possible inflammatory causes such as rheumatoid arthritis. To further confirm, I would like to review the radiographs of the hand to see if there's any.
The patient is about 20 years old.
20.
20, 20, yeah.
Yeah. Other. I'm trying to think if there's any other thing. Was osteolysis. Infectious could be a cause, but I guess bilateral is rather unusual. A differential would maybe Sappho, but I guess that's more of the medial clavicle than the lateral clavicle. In case of that, a bone scan would be helpful to see whether there's any ball horn sign.
So causes of resorption of the lateral end of the clavicle. Basically, it's that. So one you said about rheumatoid arthritis. Any other causes?
I'm just trying to think.
So we'll go to the next.
Thank you.
So this is a elderly patient presenting with pain in both hands.
Okay. So I'm presented with the DP views of the hands. Just I can see that there are involvement of the joint spaces of the proximal and distal interphalangeal spaces and joints. I could also see that these are involving also the first digit. Looking at the MCP joints, which appear normal. With not with no involvement. The CMC joints are also unremarkable and looks normal. And carpal joints do not appear grossly deformed, with no with no degree of joint spaces. So there are involvement of the distal, interphalangeal, and interphalangeal joint spaces. I'm suspecting that this may be my first differentials may are osteoarthritis, given that there's sparing of the MCP joints. other differentials are psoriatic arthritis. And to further investigate, I would like to also see whether this is a new finding or whether this is a ongoing chronic finding. So I'll compare this with previous radiographs.
How would you describe the joints? Like if you take, say, this particular joint, how will you describe it?
So there seems to be gross loss of joint space with appearance similar to a gull wing sign. So this may be an erosive osteoarthritis.
Okay, and which age group do they usually are seen?
More of the middle to older age, 50.
Okay, so and do you think you can get that kind of changes in psoriatic arthropathy?
No, so in psoriatic arthropathy, you mostly get pencil and cup appearances, and more towards the distal interphalangeal joints. There are also, but more erosions as well, but more pencil cup deformity.
So we'll go to the next case. Okay, so this is a patient with history of jumped from height, so a young patient, and there are plain radiographs of the left and the right limb. So I can show you the right one or left. Which one would you like to see first?
Left is fine. Yeah, left, lateral, and then AP would be great. Thank you. Okay, so I'm presented with the radiograph, the ankle and hind foot. Just having a look, given the history that this patient has jumped from a height, I would like to see if there's any fractures of the calcaneum, which I cannot see any apparent fracture. Trying to see if there's any other, the talus appears normal with normal mortise, which appears well preserved. Looking at the malleolus and see whether there's any soft tissue thickening. I do not appreciate any information in this region.
Okay, so that's your time, but please continue. Now you can relax, but and please describe what you see.
Okay.
So you look for calcaneal fractures, yes?
Yes. I think I can see a loosened line actually on the calcaneum, but it's more towards the lower aspect of the left calcaneum on the lateral. Just trying to also see if there's anything at the base of the fifth. I can't see any there either. Can I have a look at the other foot?
Sorry, can you have a look at the
Other foot? Oh.
Yeah. So we haven't included to try and decrease the thing. So I have other views of this foot.
Okay. Thank you. Okay, so I can see that there are increased lucency of the head of the metatarsals. I'm not sure whether that's projectional. Would you mind zooming in on them if that's okay?
Yeah.
Okay, thank you. Yes, it's slightly is lucent, but I do not. This probably is projectional. I can also see that on the oblique view as well. Yeah, it seems like they are also within the on the oblique view. The marrow on the fourth and fifth metatarsal is slightly enlarged.
Okay, so your money is in the midfoot. Okay, so I want you to let me see where I can do that and get the other one as well. That way. Yeah, so then I can get this one here as well. So I just want you to focus on, the lateral and the midfoot views because that's where your money is.
Sure, I think the navicular appears slightly thinned. And looking at the oblique view, I can't. There seems to be slight thinning and on the medial side of the navicular bone, and on the DP, there's also might be evidence of sclerosis of the navicular as well.
Okay. So one thing rule in lateral radiograph, you should be able to see the joints. Yeah. Can you actually see the talonavicular joint here? Now, where is the joint? Because you can see the joint here.
Yes.
Yeah. You can see the two surfaces.
Yes.
Where is it? Looks like navicular is. I mean, talus is here. Yeah. But then, if it looks like navicular is here, what do you think is happening here then?
Could it be would there previously be injury there, or if you can't see the communication, could there be correlation previously?
No. What we're looking at is, so this is talus. This is navicular. Where is the talus head sitting in relation to the navicular?
Oh, it's medial, isn't it? It's becoming a bit more medial.
Yeah. So this is talonavicular dislocation. Okay. So this should be sitting here. It shouldn't have an empty. It's basically like glenoid and humerus. Yeah. It's moved out, isn't it, from the articular surface? So this should be sitting here. Okay. So that's what you're seeing here. Look, it should be sitting. What is this? Why is this like this? Yeah.
Wasted, isn't it?
Okay. And this is what is happening because it's dislocated. It's not in plane at all. Okay. So and then they have I have put it here so that I can show. Then they have gone and fused it because it's been like that for some time. It's painful, and you're right. To a certain extent, you're right that there's osteopenia because of pain. Okay, so that's what has happened here. So there is talonavicular dislocation. So this is one of the in the Viva, there are few things that we don't want you to miss because ED will definitely not pick this up, and as radiologist, if you don't pick it up, nobody else will pick it up.
Right.
Okay. So that's this, and the carpal metacarpal dislocations, where the fourth and fifth CMC joint.
Yes.
Yeah. So that is the other one. So very easily it can be missed because patients will come with swollen hand, and ED will just say query injury. If you don't pick it up, they will not pick it up as well. Okay, and this also, they just come with swelling, and I wanted to show you the right because the right, it was a fracture, and that's why everybody then stopped focusing on the left, and this wasn't picked up very easily.
I see. Okay,
so that's the reason I thought, okay, I'll show you the radiograph as well, and the subsequent radiograph, when it was done, and you can see that this is your clue. See, this should be here. It should not be empty.
Fine. Yes.
Okay. And also, young patient jumped from height, so you're looking for trauma. Okay. So those are the clues on that. So always look for articulation. That will be my take-home point for you. Now you can go back and look at some more lateral ankle joints. Yeah, I don't have a normal here for you to just reinforce what it will look like. Yeah.
Sure,
So
thank
please
you.
look at that, and then it will make sense more, all the more. Oh yeah, that's not what I saw.
Got it.
Okay,
Thank
fine. So that is the last case. So we'll go back to the young patient with the chest X-ray.
you.
So let's go back to that. So now, I know I don't like lists. I also don't like lists. But for 2A also, you should know like what are the other causes of lateral end of the clavicle
Yeah.
resorption. So rheumatoid arthritis you got. Tell me some more causes.
Just trying to think.
So trauma, post-traumatic osteolysis. Yeah, usually
Okay.
in rugby players you get it, and all you will see is resorption of the thing. And
Yeah.
myeloma can cause again, lateral end of the clavicle erosions. And the other thing is this radiograph actually has a story to say. So what do you think these are?
Are they? Sorry, it's probably the resolution a bit low, but I think the is it paratracheal stripes? I can't really see. Oh no, oh there's that. Okay. Metallic clips. So
Yeah,
after previous surgery.
yeah,
Oh, uh, is it parathyroid
yeah,
adenoma?
yeah.
Hyperparathyroid within the causes
Yeah,
tonsillitis.
I showed the knee radiograph last time. Yeah,
Yeah.
and you can see the resorption in the inner end of the humerus as well. So we said the medial aspect of the tibia can have resorption
Mm.
in hyperparathyroidism.
Yeah.
Okay, so you see that resorption here, and lateral end of the clavicle erosions are also feature, and the fact that there are clips there. So this is like really young patient who was having this radiograph. Uh, he was having bilateral pain, so they thought let's get a chest X-ray to see what is happening, and it was post-operative.
Mm.
Okay, so
Oh,
and
okay.
this is post-operative for parathyroid adenectomy.
I see.
Okay,
Yeah.
so lateral end of clavicle, some lists you may need to know, and please put
Mm.
this in one of the lists that you need to know the causes. Yeah.
Got it. Thank you.
Okay, fine. Okay, so that is the other one. So then it was, oh yeah, so 27 case number. Load. So this one, yeah, you picked up well, because sometimes the fibula lesion is easily missed. Everybody is focusing on the bigger bones, and you can miss this. So well done. Described it well. Said it's aggressive. Only thing is the um, history that is given is usually one liner. Yeah. So I know it's too many things to think about. So but just again reinforce. Oh, can I just check the age of the patient? Because
Mm.
then your differential completely changes.
Yes.
Yes. So just ask. I know there's just too many things going on, but please ask. Oh, can I please confirm the age of the patient?
Mm.
And or you can say, if it is this age group, this will be my differential. If it is this age group, this will be my differential. Then I know. Okay, you have an approach, different approach to depending on the age.
Mm.
Yeah.
Mm. Mm. Mm.
So yeah, agree that if it's a very young patient, then you wanted to give Ewing's, and that's a good differential to offer. But this was a 45-year-old, very unusual. But this turned out to be a colonic metastatic
Brilliant.
deposit.
Okay.
Yeah.
Fine.
So
Yeah.
don't forget in older patient to give MET as one of the things.
Mm. Sure.
Yeah. So you said lymphoma, that's also a good call. But if you look at the bone, you usually get more sclerotic areas and things like that in lymphoma.
Yeah.
So this is more lucent with periosteal reaction. But I wouldn't say lymphoma is completely wrong. So that's a good call. But don't forget MET.
Mm. Sure.
Okay.
Okay.
So
Thank you.
that's good. So next one. Um, so case number 36. So I'm just trying to keep to my theme. So I said in the last session that, definitely I'll show you one periprosthetic so that I cover most of it, and all the hands, the different kind of arthritis. So I think we did gout last time, and we did psoriatic. Yeah. So this is typical of, after when I asked you, then you coned into that, and you said yes, erosive osteoarthritis. Yeah. But elderly female patient, this distribution, it's usually erosive osteoarthritis.
Okay.
Okay, so uh, and that's the typical presentation, and they will have, the Heberden's nodules and, soft tissue swelling in these knuckles as well. Okay, so that is typical. And how you know it is um, like OA rather than psoriatic? I mean, they may question you. Yeah. So don't feel, oh, I must have got it wrong. That's why they're questioning. They're just questioning so that they know that you know the difference, and you're trying to tell them that. Yeah.
Sure,
So
sure.
for psoriatic arthropathy, they are periarticular erosion, whereas this is central part of the joint that is involved.
Got it, got it. Yeah.
So the central part of the joint is involved, and you can think about it like, like the weight bearing part of it, like, the articular surface. Yeah? Whereas the psoriatic arthropathy is periarticular because of the synovitis changes. You get erosions in this part of the thing. That is what we call the bare area of the bone, because you have the synovium attachment, you have the cartilage still there, and this area will be unprotected, and therefore you get erosion in that area. So that's why you get periarticular erosion in rheumatoid arthritis and psoriatic arthritis. Whereas in this erosive OA or osteoarthritis, it is centrally based, and that's why you get, a seagull appearance. You can see it looks like, when we draw birds, we draw it like that, isn't it? Yeah. So that's exactly what, seagull appearances. And once you start using, term like that, you cannot sure describe it. If you are very sure that's what it is, use the terms like penicillin cup for psoriatic or seagull appearance for osteoarthritis, and then you can finish it.
Got it. Thank you.
Okay. So for 2A also, arthritis, all four, and crystal arthropathy, it should be literally like the back of your hand.
Yeah.
In this case. Okay. Fine. So I think we have done. I haven't. I have done all your cases. Yeah. Any questions in that?
No, I think that's pretty clear. Yeah, thank you so much.
Oh, yeah. No worries. And well done. So you'll be absolutely fine. Just do the description, and all of you keep forgetting to ask for the other view. Please ask for the other view. So I in your case, it didn't contribute much, but we want to see what your practice is. So please don't report on one view. Yeah.
Got it.
Okay.
Thank you.
Well done. So candidate number 4, please.
Yes, doctor. Good evening.
Good evening. So we will start off with your first case. So case number. So I'll show you the AP first, and then I can show you the lateral.
Yes, I've been provided with the AP view of the right wrist in a skeletally mature patient. So at first instance, I can see that there are two lytic lesions in the subarticular aspect of the distal radius. One of the lesion is located in the subarticular metaphyseal region. The other lesion is located in the metadiaphyseal junction. So I can see that both the lesions are relatively well defined with the narrow zone of transition. I can see some soft tissue swelling or prominence around the distal radius. So apart from that, I don't see any. Can I zoom the image? Yeah. So apart from that, I don't see any pathological fracture. I don't see any kind of cortical break or erosions in this surrounding the lesion. The bone density appears to be grossly normal. So, with all these findings, the rest of the bones also to the visualizations are normal. There's an incidental note of a lunula adjacent to the ulnar stellate process. So, with these findings, because it's a skeletally mature patient, the first differential I would think of is a metastatic deposit, most likely from the lung because it's located in the peripheral skeleton. The other differential I would think of is if the patient has any history of fever or any tenderness, I would think of it to be some kind of infective process. Uh, so I would look into the history, take the clinical history from the clinician. If the patient has any history of malignancy or if the patient has any systemic infection or other things, and then would further uh, first check the lateral view for this case, and if the lateral view is normal, I would go for a the lateral view also shows that there is, yeah, the lateral view, yeah, it's I can see only one of the lesion in the lateral view, which is the metadiaphyseal region lesion, and the other lesion is not clearly seen here. Yeah, so my differentials will be the same. If the patient has history of any pain, swelling, fever, then I would go for an infective cause. If the patient doesn't have any of these symptoms, then because it's an elderly or a skeletally mature patient, metastatic deposit would be the first differential in this case.
Okay. The patient is unwell.
Patient is unwell, then metastatic deposit is the first differential I would think of in this case.
Okay. Mm. And if they have pain as well associated with the thing.
If they have a pain associated with this, then I would think of,
So it's painful and they are unwell.
okay, then I would think of infective process. Maybe it's a Brody's abscess because there is a sclerosis here in one of the lesions here. So, and it's in the metaphyseal region. So, because of that, I would think of a Brody's as abscess or a subacute stage of osteomyelitis. Um, Maybe because it's a middle-aged patient, if there is a history of drug abuse, IV drug abuse, then that could be one of the cause in this case.
Okay, so what will you want to do next?
Yeah, I would first uh, I would refer this patient to the orthopedic team. I would look into the inflammatory markers for this patient, and based on that, I would go for a cross-sectional imaging. Most likely, MRI of the wrist would be helpful to know the soft tissue extension and the intramedullary extension of this lesion.
Okay, so MR of the
Okay, so this is a fat suppressed fluid sensitive sequence which is taken at the right wrist joint level. So I can see that, yeah, both the lesions are uh, clearly seen, and their hyperintents on the fluid sensitive sequence, and the lesion, the proximal lesion here, is having a sclerotic rim. There is also a bit of cortical thickening over here, adjacent to the distal radius, predominantly in the radial aspect. There is soft tissue swelling, which was was seen clearly on the radiograph over here, predominantly in the radial aspect, extending to the anatomical slough box area, and I can see that there is some kind of a soft tissue lesion here. I would like to,
what would you like?
yeah, axial image, if there is any axial. yeah, there's a cortical break here uh, in the radial aspect, and this cortical break is leading into a subperiosteal and deep soft tissue walled off collection. I'm trying to look for any uh, hypointense focus inside. So this there's a newborn formation also over here, and I'm trying to look for any uh, sequestrum, but I'm not seeing it in this image. Can I just have a look again? There is a hypointense focus here within the center of this lesion. I will see this on the other E1 image, and then this is a post contrast image. Yeah,
Okay.
showing. Yeah, yeah, we can see on post contrast image that the lesions are showing peripheral wall enhancement, and the cortical break and the soft tissue components also showing peripheral enhancement. So this is a case. So based on all these findings, I would make a principal diagnosis of subacute osteomyelitis with Brody's abscess leading to cortical break and subcutaneous collection. That would be my first definition I would think of in this case. Because the patient is unwell, uh, yeah, I would further uh, refer this patient to orthopedic team for a biopsy to isolate the organism and further start the appropriate antibiotics.
Fine. So we'll go to the next case. So this patient is presenting with right-sided pain.
Okay, so I've been provided with the APV of the pelvis in the proximal femur. So I can see here that there is right hip uh, replacement prosthesis in situ. I can see multiple like particles, soft tissue of paste is not adjacent to the right hip joint, and in the right acetabular roof, superior to the uh, femoral head of the process, I can see a smooth, smoothly defined lytic lesion. Uh, so I would like to have a look at the this acetabular roof. I can see some uh, smoothly defined area over here.
Mm-hmm.
So so that is well defined and it is oval in shape. I would like to have a look at the orthogonal view or the lateral view if available. And in this view, I can see that there is a well-defined yeah, oval-shaped lesion, lytic lesion in the superior lateral aspect of the acetabular roof. Apart from that, lucency adjacent to the femoral stem is normal. So this is suggestive of a granulomatous lesion secondary to like particle like deposition. So yeah, not sure about this.
Okay. So what will you do next? What do you want
Yeah,
to do?
I would just take the history, refer this patient to the orthopedic team for
Mhm.
further management of this case because I think they will need to do a revision surgery if this granulomatous deposition.
And if they ask, can you do some more imaging? What would you suggest?
I would suggest an MRI of the right hip for further confirmation of this pathology.
Okay. So MRI of the right hip.
Okay. Yeah, MR of the right hip, yeah, shows a large soft tissue. Okay, there is a large soft tissue at intensity, isointense T1 isointense lesion noted uh, adjacent to the right hip joint, which is extending along in the right hemipelvis and also inferiorly along the right proximal thigh. So this is okay. So I just would see the fluid sensitive stare or T2 images to see the signal intensity, and this is iso intense on T1, and on this sequence it is hyper intense. Yeah, so it is yeah. So I would do a contrast to see whether there's any enhancement within this lesion. So with this,
There's no enhancement
yeah.
of
So
this
then I
lesion.
would, yeah, then I would think of uh, like aggressive granulomatous lesion post post hip replacement. This needs revision surgery, and yeah, that's the treatment part.
Thank you. So moving on to the next case.
Okay, so I've been provided with our DP views of both the foot, and at first instant I would like to zoom this image. Yeah, at first instant I can see that there is juxta-articular erosions noted adjacent to the uh, metacarpophalangeal joint of both the both the first great toes, and these juxta-articular erosions are showing overhanging edges with adjacent soft tissue swelling. There are also some juxta-articular erosions adjacent to the fifth metatarsal head, and there is also some subchondral lytic lesions adjacent to the proximal phalanx, base of the proximal phalanx of fourth toe. So apart from this, yeah, so based on these findings, I'm trying to look for any soft tissue calcifications which are not present in this case. There is soft tissue swelling, but there's no hyperdensities within the soft tissue swelling. The similar findings are also seen in the right fifth metatarsal head and also in the fourth metatarsal head. Yeah, third, fourth, and fifth metatarsal heads. So based on this findings of juxta-articular erosions with overhanging edges and soft tissue swelling, I would think of a crystal deposition disorder, something like gout, as my top differential. The other differentials I would think of, and the bone density is fine in this case, and there's no uh, osteophytes or other degenerative changes. Yeah, so I would think of a crystal deposition which is like a gout as a top differential in this case.
Okay, fine. I
Yeah,
think that's your time. So well done. You can relax now. So I mean, I think for any other differentials for this at all, or would you
yeah,
say
yeah. Other differentials would be, can also think of uh, rheumatoid because it's involving the proximal metacarpophalangeal joints. We can think of rheumatoid arthritis, and multiple joints are involved. Metacarpophalangeal with subchondral cysts and maintained and a little bit of periosteal osteopenia and soft tissue swelling and no periostatus. Yeah, you have to think of rheumatoid as the first definition. Yeah.
yes, yes? Okay, so
Yes.
because I was like, why is he not giving rheumatoid at all? Like because I agree with this particular thing. And remember, in elderly patient, you can have gout coexisting. Yeah, but if you look at all these here, they are all periarticular. See,
Yes.
close
Yes.
to the articular surface. So they're all periarticular. See, look at that one. So they're all
Yes, yes.
periarticular, and you'll have to think about it's very symmetrical. It's MTP joints bilaterally equal to MCP joints in the hand, and look at that. So it's all a lot is periarticular rather than juxtaarticular. I agree with you in the toe there is one, and you can say that, oh, could it be like coexisting gout as well, but once you are not on the hot seat, you told all the features of rheumatoid arthritis. Yeah. Okay. So just think bilateral, symmetrical, and the distribution is MTP, and you know many of them are periarticular rather than very away from the joint, and based on
Yeah.
all that, yes, it is rheumatoid arthritis. Okay, so that
Yes.
is that, and it is just part of the thing that I wanted to cover RA as well, to make sure you all have seen all the major arthritis cases. Okay, fine. So that is that one. um, 30, 30, very well done. Because it's a pseudotumor or the reaction. So this is the thing, and you said there is also these findings here. Now you can relate to that, isn't it? Because all this is lucent because of what we saw
Yeah.
on the MR. Yeah,
Yes,
and
yes.
MR actually, let me load it together. So MR then confirms what you have seen, and you can have again, in the other case we saw a lot of fluid in the iliopsoas bursa, which was another manifestation of alval or reaction to the metalwork, and that's what is happening here as well. And that's why it's low signal on all sequences, like, because it will be a combination of some fibrous tissue and reaction to the like granular mattress tissue reacting to the metalwork there. So yes, so that was really well done. You said what is happening here, what is happening here. You sort of wanted to give up here, but then when I said what else will you want to do, you looked at the MR and then you said, yeah, this is definitely secondary to the metalwork. And you're right, they have to have replacement, and they went on to have complete, they removed all the metalwork and then replaced it with new processes. So absolutely good on that. Then the next case that you had was 35. So this one, I think you picked it up afterwards, but the other observation, look at the radius itself. Do you think the bone density is normal?
Yeah, it's actually increased in bone density with little expansion, sclerosis also.
Yeah. So you lost actually, the corticomedullary differentiation. Can you see?
Yeah, it's lost. Yeah.
Yeah, it's completely lost, and there's increased sclerosis of the bone there, and you lost the fat planes here. Yeah, that's because of all that inflammation that you have, and
Okay.
then that's your sequestrum, isn't it? The dead bone. Yeah.
Yeah. Okay. Actually, I could see it in MR. I didn't pick it up here.
Yeah, because I think actually it's more difficult to spot on the MR because of the resolution. Yeah, whereas here I was trying to do that and show you like, but again when you said, oh, I will consider osteomyelitis, I was trying to do that to show, but that's what you're looking for, and
Okay.
that's what is there. So all features of osteomyelitis actually are seen here. I think. Lung mets is a good thing, but suddenly getting two metastatic deposits, very rare, isn't it?
Yeah,
Like,
very rare.
so that's very rare. And increased sclerosis. See, the bone is abnormal actually from here till here.
Mm,
Yeah, if you look at that, and having
yeah.
so much of soft tissue swelling with
Soft
it.
tissues. Yeah,
Yeah,
actually, infectivity should be the first top differential.
yeah,
Yeah.
yeah. So that's why I was trying to push you towards that, because you were giving me meds as the first one. So then I gave you history, or patient is unwell, thinking that unwell like pyrexial. But I think that sort of put put you more, oh, it must be met. So, but think about, okay, from here to here, lung met is rare, two of them, soft tissue swelling, all those features. Okay, I'll go more for infection. You can always have met in your differential, but I would say infection will be the main thing here, and also the fact that you have the lesions here. So I think you described this very well, because each examination I'm showing counts as one. So you can't say that, oh, I saw only three films, three cases. Yeah, each examination is one encounter. So this is one, and then they show you the MR. You have to describe the MR. So that's, although it is like three cases, you have seen four exam or five examinations, because you have seen different modality, and because they want you to say what's happening here. So it has breached, yeah, and then you can see all the collection here, yeah. So
Yeah.
then next thing, it will form like a sinus, like it will start accumulating out there. So that's what has happened here. So it has breached, and it has decompressed, isn't it? Otherwise,
Yes.
it's
Yes.
just found its way out, the pus.
Yeah.
And that's what on the post contrast.
Enhancement was there. Yeah.
Yeah. So can you see? That means this is
Yes.
pus. Yeah. Now, if the
Yeah.
surgeon goes and tries to, get something from there, he will say, "Oh, I think you were wrong. There was no pus at all." They have to go for this, because this is fluid, and that's why it's not enhancing. Whereas this
Mm.
is like a little bit more chronic, like it's dead, and it's enhancing. Yeah. This
Okay.
is the bit that will be like fluid. If they put a needle in, they will get pus there. Yeah.
Okay.
So having that post contrast to show that the fluid collection, where if they want to aspirate, that's what they need to go for. Yeah. This will be like a biopsy, and they need to culture, because if they put a needle in, they're not going to get pus there.
Yeah.
So that will be this one. So well done. So that is infection, and you're right. Actually, there was history of some drug abuse or immunocompromise, and that's why they had this, because it's a very unusual sight in an adult patient to have osteomyelitis there. Okay, so that was that. So tumor, pseudotumor, and RA. I think those were the cases that we saw. I'll just show, to finish off. I just have 1 minute. Dr. Khan, can I just show one film and then I'm done?
Thank you so much, Doctor.
Thank you. Thanks a lot. So this film is just for everybody on chest X-ray. Make sure that you see the bone, and you can see the increased sclerosis, the expansion of the bone compared to that. I just thought I will share this because you see patches of hemipelvis, but this is patches of the scapula. Okay, fine. So I will stop sharing, and I think we just managed to finish on time. So
brilliant, absolutely brilliant. I was listening with a lot of attention. If there are any questions by the candidates, particularly the last candidate or anybody, you can speak up. We can give you 5-10 minutes.
Hi, I'm candidate number 2. Can I ask one question if that's
yes,
okay?
please, yeah, please go.
Yeah. So in the first case, for candidate 1, where there were cortical-based lesions, so bubble appearance in the femur, I actually wanted to ask, like, can eosinophilic granuloma be a differential in that young age and well-defined?
Yes, yes, you can give that as a differential. But my main emphasis on that case will be the fact of, I'm just trying to load up that case for you. I'm just going to get that. So case 13, load. So my main thing, candidate number 2, for that will be the location of the lesion.
Okay.
Yeah, it's cortically based. That is the key to just figure out where the lesion is. And what I say is an elephant is an elephant whether on land or sea. So, if there are cortical based lesions and you are thinking about non-ossifying fibroma, doesn't matter if they are multiple, and we haven't come across it. But the main thing is the description, the soap bubble appearance. If you look at you can draw with a pencil, isn't it? It's a very narrow zone of transition. Would you agree with that?
I think your screen is not shared.
Oh no, that's because I stopped sharing, isn't it?
Yes.
Reserved it. So let me go back. I've been zooming and trying to show you and everything. Window advanced share. Am I sharing now?
Yes.
Okay, fine. So so if you see, you can draw around it, right? You can
Yes.
draw nicely around it. Okay, so it's well defined. And remember that soap bubble appearance of the non-ossifying fibroma. That's what you're seeing, like from the side, as if you're looking at it from the side. Yeah, and
Okay.
the fact that it is cortical based. So you can give non-ossifying fibroma, but I think the examiner will ask, where are these, where are the located? Are they medially or are they cortically based? And if it's cortically based, it's benign. There's not much, not many more things that you can think of. Yeah.
Okay. Yes. Thank you.
Okay. No worries.
Priya, there was a question in the chat about, there was a lesion which was chondroblastoma, and the question is, could it be an enchondroma? That is the question.
Okay, fine. So I'll go to the chondroblastoma. Oh, that was candidate two's. This one, she nailed it nearly. Where is that's case number 26? Sorry, that's not the case. So there, that's number 26. Okay, so enchondroma in epiphysis, because of where the location is, young patient, and the size of the lesion, that will be a chondroblastoma. If you want to say, could this be enchondroma, the same lesion, if it was in the metaphysis, then you will say it is a chondroid lesion of unknown malignant potential, because when they occur in the small bones of the hands and feet, you can say, oh, chondroid lesion, and it's in chondroma. But when they start occurring in the more long bones and more proximally within the pelvis, you're not sure about the malignant potential, so they are called clump, that is a chondroid lesion of unknown malignant potential. So I think for this one, examiners would like to hear that it is a chondroblastoma because of its location and age and appearance. Is that all right?
That is absolutely fine. And
and the other question was, there was no calcaneal fracture. No. And remember, you can have in the calcaneum, you do have lucent areas that is like within normal limits, because you can have fibrofatty changes as in the calcaneum. So you can get what you call like pseudo lesions in the calcaneum. So there was no calcaneal fracture in that. The main thing in that would be, please look for articulation, and don't miss talonavicular dislocation.
so I think, thank you very much, Priya. It was absolutely marvelous. And I think both of your sessions, what was the ISO intense? I think both of them were absolutely marvelous sessions, and we hope to see you soon back on the forum.
Thank you. Thanks a lot. And thanks to all the 4 candidates also, Dr. Khan, because they have put themselves forward to make the session useful for others. And it's not a easy thing to speak in when so many people are listening. So well done to the candidates as well. So thank you for your help to make the session more educative for others. And good luck to all the candidates. I'm sure you'll all be fine. Good luck.
Yeah.